ahead. Have the mic? Yeah. Thank you, Hani, for having me here. I think let's talk about subepithelial tumor. I don't know how many of you are really doing these procedures, but of course, you must be encountering these tumors. Whenever we do endoscopy, we see many subepithelial tumors. So it's my job to tell you how to manage or how to ignore them or when to ignore them, when to treat them. So we must discuss the common causes, then think about how to reach the diagnosis. Let's start this case. I saw this case few days ago when I did an endoscopy for a patient who was on renal transplant, and then the CT scan showed a 2 centimeter tumor in the gastric antrum, and previously it was 18 millimeters, so it's increasing in size. It's now 24 millimeters. So now question is how you treat this case, whether you can leave it alone and do more surveillance, or do an endoscopic ultrasound and biopsy, or do send this patient for surgery, or do endoscopic resection. So these are the 4 options which we have. So let's talk about subepithelial lesions. Subepithelial lesions can arise anywhere in the gut wall below the epithelium, either from submucosa, muscularis propria, or from the muscularis mucosae. And they are mostly incidental and mostly less than 2 centimeter in size. So we must know that these subepithelial tumor are always not benign, but less than 15% are malignant. What are those malignant? Like lymphoma, high risk GIST, and there are certain pre-malignant or potentially malignant which can convert into malignancy like GIST or neuroendocrine tumors. But certain lesions can be ignored like lipoma, leiomyoma. So majority of the lesions are mesenchymal tumors, either GIST or leiomyoma. The second category is carcinoid. So we must know this. So how to diagnose? Do an endoscopy followed by an endoscopic ultrasound followed by histological diagnosis. So these 3 are very important. Why endoscopy? Because as soon as you do endoscopy, you know if the lesion in esophagus, majority of them are leiomyoma. If stomach, the majority are GIST. GIST are pre-malignant, leiomyoma are not. So we must know the location of the tumor. So based on the location, I can have a diagnosis. Okay, this subepithelial tumor can be GIST in stomach, or this subepithelial tumor can be a leiomyoma in esophagus, or can be a carcinoid in the duodenum. So we know the specific location where the subepithelial tumor may come. Now once you do endoscopy, you must see few things. Like you are doing endoscopy, try to compress it. And if there is a pillow sign like this, which is a soft, it's a lipoma. So leave it alone. Don't do anything unless they are symptomatic, causing obstruction, bleeding. If they are asymptomatic, leave them alone. Pancreatic rest, there can be a antral lesion with central depression. You can leave it alone. Or there can be inflammatory fibroid, which is bulky tumors in stomach, and they are very classical. So by endoscopic appearance, we can say that this is this lesion. So our case, which we did, has a tumor in the antrum, which is around 20 millimeter. It is firm. It is not pillow sign. Mobility is absent. Pulsation is absent. So no vascularity. Ulceration is absent. So our case is not a lipoma, and we need further evaluation. So what is the further evaluation? Do an endoscopic ultrasound. Why? To see which is the defined. So there are 2 things which we see in endoscopic ultrasound. From which layer the tumor is coming, and what is the echogenicity of the tumor. Say for example, a lesion which is hyperechoic arising from 3rd layer, it is lipoma. Or patient who has anechoic like a cyst arising from 3rd layer, it is cystic lymphangioma, or you can have a duplication cyst, or you can have varices. So these lesions require different approach, but the most common is hypoechoic lesion. Now if hypoechoic lesion is arising from 2nd layer, it is mostly neuroendocrine tumor, or if it is arising from the muscle layer, the MP layer, muscularis propria layer, then it can be GIST or leiomyoma. So see the echo level and see the layer and decide which is there. So in our case, okay, so another thing about endoscopic ultrasound which will clearly tell you is the lesion which are outside the wall. But endoscopy, they look like intramural, but as soon as you put an echo endoscope, you can find mass from the gallbladder protruding into the lumen or so on. So you can have a quick diagnosis that it is not intramural. The second thing which we should endoscopic ultrasound tell us is whether it is malignant or not. If there is a GIST which has no ulceration, less than 3 centimeter in size, smooth margins, they are non-malignant. While if there is a ulceration present, more than 3 centimeter, irregular margin, there are necrotic areas, there are heterogeneous foci, they are most likely malignant. As soon as you have a doubt that this is GIST is a malignant, it rules out endoscopic treatment. Go for surgery. So endoscopic ultrasound told us that which layer, what is the echogenicity, and whether it is malignant or not. In our case, we did endoscopic ultrasound around 25 millimeter mass. It is arising from MP layer. It is heterogeneous, well defined. There are no lymph nodes and the internal perfusion present. There are no necrotic areas, no ulceration. So this is a benign hypoechoic lesion arising from MP layer. So this is a benign GIST arising from gastric antrum. And as I said, GIST are never totally benign. They are potentially malignant. This has not already converted into malignancy, but this patient may have, so it must be removed. So we know that by endoscopic ultrasound, by the imaging, that this is a GIST which is potentially malignant and is amenable for treatment. Now, before embarking upon invasive treatment, we must have a diagnosis. So, how to take a diagnosis? To take a tissue. The tissue can help us in reaching to the diagnosis by immunohistochemistry. Like, say, for example, the KIT is positive, it is GIST. If KIT is negative but CD34 positive, DOG1 positive, again it is GIST. But if all these mutations are negative, then Desmin positive leiomyoma, S100 positive schwannoma. So if we can diagnose this as a GIST, it requires immediate treatment. If it is leiomyoma or schwannoma, it may not require immediate treatment and can be followed up. So it's very important to take tissue diagnosis. How to take tissue diagnosis? Various modalities have been shown, like they can be, the evidence is poor, but any SCL more than 20 millimeter arising from MP layer requires a tissue diagnosis. Tissue diagnosis can be done by biopsy, but biopsy will take epithelium and we are dealing with a subepithelial tumor. So it may not give a correct diagnosis. So we know that if you have a larger biopsy forceps like a jumbo biopsy forceps, or you may have to do unroofing. You have to remove the epithelium, expose the tumor, and then take biopsy. So this is another method. FNA is a method, but the sensitivity is very low. The second method or the best method is FNB, shark core needle or Francine needle. They give us a better diagnosis as compared to FNA. So bite on bite biopsy is possible. FNB is better than FNA. You can also do mucosal incision, expose the tumor and then take biopsy, which is also good. Once you have a diagnosis, so if you are dealing with gastric carcinoid or GIST, you can go ahead with the treatment. Now gastric carcinoid, I do many endoscopy in India and I see many nodules like this. These are gastric carcinoid. So whenever you see multiple gastric nodules, always do a serum gastrin level. If serum gastrin is increased, that means these are hypergastrinemia related tumors and this can be type 1 or type 2. But if the gastrin is normal, then the type 3 tumors. Now, it is very important for us to understand whether we are dealing with type 1 or type 2 or type 3 gastric carcinoid. If type 3 gastric carcinoid, which is normal gastrin carcinoid, is aggressive tumor and requires surgery, while type 1 are very common and we may leave them alone if they are less than 1 centimeter. If they are type 2, they are associated with Zollinger-Ellison syndrome or MEN. and they require treatment. And if the lesion is more than 1 centimeter in size, they may require endoscopic treatment. What is the endoscopic treatment? The easiest endoscopic treatment, say for example, this is the duodenal neuroendocrine tumors. What we do is band ligation without resection. You can just suck these tumors inside the band like a varices, and once you apply the band, it cuts off the blood supply and these tumors falls off. So this is one, but here we don't get histology, but sometimes this is known as sink biopsy, where we need to have a band application, needle knife, and take biopsy. So we have tumors which are less than 10 millimeter in size can be treated like this, which is very easy method. I'll not go into the detail. This is again a rectal carcinoid which is being treated by band. But here we are taking the, once the band is applied, it create a polyp type structure, and then you can cut below the band and you can have EMR. This is known as endoscopic mucosal resection. Here you have a full tumor in your hand and you can take biopsies. The gastric NETs, which are larger than 1 centimeter size, you can see these are type 1 gastric NET, but the one NET is very big and this requires removal. And this can be done by ESD, and endoscopic submucosal dissection allows you to dissect between the tumor and the muscle and you can remove the complete tumor, while rest of the NETs can be removed by band ligation. So this is how we treat type 1 gastric carcinoid which are more than 1 centimeter in size. So this is ESD. The second method of treatment of this is the gastric carcinoid arising from submucosa. So you can do dissection. But what if they are arising from MP layer, muscle layer? They need full thickness resection. And the tumors which are arising from esophagus, they are mostly leiomyoma, and those which are arising from stomach are mostly GIST. And this is one of the tumor which is being removed by STIR. This is known as submucosal tunneling and endoscopic resection, where the tumor you approach by a tunnel and then you dissect between the tumor and the muscle, and also tumor and the mucosa. This is the mucosa side, and these are the tumors which are arising from muscle layer. So you must approach them via tunnel and remove these complete tumors. This is known as STIR. You can see we have removed complete the tumor. This will go for histopathology and we'll know this is curative resection or not. And this is the tumor removed from the tunnel, and whole tumor will be available for, and then you can close this tunnel. And this is the whole tumor, this is the leiomyoma. The second thing which can happen in stomach is they are arising from muscle layer, and you cannot do ESD because there is no gap between the muscle and the tumor. And here you have to do full thickness resection. This is the outside the gastric wall, and you can do complete resection, but then subsequently you have to close this full thickness defect. And this is known as EFTR, and this is how the gastric GIST arising from the muscle layer are treated. So that is EFTR. I'll not go into this. So we can remove these tumors based on the diagnosis. Mostly STIR is indicated in the esophagus, that is leiomyoma or gastric GIST. Some of the tumors can be removed very safely by new methods, and these are like rectal NETs or subepithelial tumors where you have a OTSC cap. You can see there is a cap and the tumor can be sucked into the barrel, and then there is a clip which is applied which brings serosa to serosa together and you can cut across. So this is known as a FTRD device. There is a full thickness resection device from Ovesco company where you can bring this tumor inside the barrel and then cut. And you can see the complete serosa to serosa approximation is done, and you remove full tumor, and then you have a full histology available. So you saw that how these tumors are being removed, and majority of the patient whom the tumor is less than 2 centimeter in size, ESG recommend surveillance. But our patients are very anxious. They want if the diagnosis is not there, sometimes even the society guidelines say that to avoid unnecessary follow-up, and if endoscopic resection is easy, even less than 2 centimeter polyp of unknown histology should be removed by these methods. So in the end, I will tell that whenever we have a subepithelial tumor, we must do symptom analysis. If patient is symptomatic for any tumor, it has to be resected. If it is not symptomatic and you just found when you are doing endoscopy, do a good endoscopy and EUS and see whether the lesion is completely anechoic or hyperechoic. If both the things are there, that means it is either a cyst or lipoma. No biopsy. Patient should be sent home. While if there is a hypoechoic lesion, then you must go into the deep layer, whether it is arising from muscularis mucosa or submucosa. It may be a neuroendocrine tumor, you must remove it. Or if there is an MP layer tumor, you first take biopsy, and based on whether it's a GIST or schwannoma or leiomyoma, you can take a decision whether it's to be resected by EFTR, endoscopic full thickness resection. So our case, you saw this patient had a hypoechoic tumor arising from MP layer, gastric antrum. It was a gastric GIST, and patient was referred, wanted a surgery, but the surgeon sent back to us that you remove, and then we removed this tumor, which was gastric GIST. So take home message for management of subepithelial tumor: start with history and thorough endoscopic examination. EUS is the modality of choice for characterization for indeterminate subepithelial lesions. Extrinsic compression, cyst, varices, lipoma are easy to distinguish, and hypoechoic subepithelial lesion are difficult. There is no cutoff size for EUS FNB. The management depends on the histology, size, location, local expertise, and primary endoscopic resection can be considered for these small SEL. With this, I thank you very much for your attention and will be happy to answer any questions.